Most arguments about gender affirming care fall apart before they even begin. Not because people disagree on values, but because they're arguing about something they haven't clearly defined. When many people hear the term gender affirming care, they picture one thing: surgery. But that mental image doesn't match how gender affirming care actually works, medically, psychologically, or practically. So in this video, I want to slow the conversation down and explain what gender affirming care really is, what it looks like at different stages, and why so much of the public debate focuses on the rarest parts instead of the most common ones. Gender affirming care isn't one treatment, it's a framework of support. At its core, gender affirming care means supporting someone's gender identity in ways that reduce stress and improve quality of life. And that support can be social, psychological, or medical. And which of those apply depends entirely on age, individual needs, and context. That's important because most gender affirming care doesn't involve medical intervention at all. The biggest misconception is treating gender affirming care like a single medical procedure, when in reality it's a spectrum of care, most of which is non medical. When public debates about gender affirming care escalate, kids are almost always brought up first. And that's where the most misinformation tends to live. For children, gender affirming care is almost always social, not medical. That means things like using a child's chosen name, respecting the use of their pronouns, allowing changes in clothing or hairstyle, and providing support at home and at school. There are no hormones involved in that stage. There are no surgeries, and importantly, social steps are reversible. If a child's understanding of themselves changes over time, nothing permanent has been done to their body. So when kids are used as the centerpiece of medical panic, what's really happening isn't a discussion of medicine. It's a misunderstanding of what care for children actually involves. Puberty blockers are one of the most misunderstood aspects of this conversation. They're often described as if they change children. But puberty blockers don't change anything. They pause something that's already happening. Puberty. That's it. The purpose of puberty blockers is time. Time for exploration, therapy, and certainty without forcing irreversible physical changes to happen first. And if puberty blockers are stopped, puberty resumes. That outcome has been observed repeatedly. These medications have also been used for decades, including on non-trans children with precocious puberty. So the debate around blockers isn't really about unknown treatments. It's about how a familiar medical tool gets reframed when it's associated with trans healthcare. Another common myth is that hormones are the starting point of gender affirming care. They're not. Hormones are typically considered later, after careful evaluation. That process includes persistent gender dysphoria, medical screening, and informed consent. Once prescribed, hormones are monitored. They're also adjusted over time, and they are treated like any other long-term medication. And to be very clear, hormones are not given to young children. So the real issue here isn't hormones being rushed. It's people misunderstanding or misrepresenting how the process actually works. Surgery dominates public discussion about gender-affirming care, even though it represents the smallest part of it. Surgery is rare, especially for minors. When surgeries do occur, they're typically for adults after years of consideration. They require evaluations and consent and clear medical necessity. This isn't experimental medicine. It's regulated healthcare. So when surgery becomes the centerpiece of the conversation, it doesn't explain how gender-affirming care usually works. It explains how the story gets distorted. Gender-affirming care doesn't exist because of politics. It exists because of outcomes. Healthcare decisions are made by looking at evidence. Does this reduce distress? Does it improve quality of life? And the evidence shows that for many people, individualized gender-affirming care does exactly that. Denying care doesn't make people not trans. It increases harm. That's why gender-affirming care isn't one size fits all. It's tailored to individuals based on evidence and ongoing evaluation. Another persistent myth is that gender-affirming care is impulsive. It isn't. These decisions aren't made in a moment, and they aren't made by one person. They involve the patients themselves, their families, their doctors, and mental health professionals. They follow guidelines, use assessments, and involve ongoing monitoring. Which means the loudest voices online are rarely the ones making these decisions or living with the outcomes. Gender-affirming care is careful, deliberate, and evidence-based. When you zoom out, a pattern becomes clear. The public conversation about gender-affirming care focuses on the rarest interventions, the most emotional framing, and the least accurate descriptions. But the reality is quieter, slower, and far more structured than the panic suggests. Understanding how gender-affirming care actually works doesn't require agreement on everything. It just requires starting from facts instead of fear.